So basically, I just need to admit them. Nisha, is that all I need to do?
Yes, please.
Okay.
Colleagues, we'll be starting shortly. We're just giving a few of our speakers and discussants the opportunity to just join, and we'll be starting in the next minute or two. All right. Good afternoon, everyone. I trust you can hear me and that you can see me. A very warm welcome from a blustery Cape Town on this Friday afternoon. I'm Nisha Jacob, a public health physician at the University of Cape Town. I work with the MeSH consortium, that's the Measurement and Surveillance of HIV Epidemics Consortium, supported by the Bill and Melinda Gates Foundation. And I'm delighted to welcome you all to the fifth of a series of MeSH EPI meetings and the last session for 2022. The aim of these meetings is to take some time from our busy service-driven lives to reflect and critically review our HIV data with an epidemiological lens. You can view previous sessions of these meetings on the MeSH YouTube channel. Earlier this year, some of you would have joined us for a very enlightening session on HIV PrEP. And based on stakeholder feedback from those who work in the services, our last session this year is on differentiated service delivery, often a bit of a confusing term that we hope to shed some light on today. We have speakers from diverse health backgrounds lined up today representing different DSD perspectives, followed by a discussion led by expert discussants involved in DSD in different roles. And I will introduce each of our speakers and discussants as we go along. But just before we start, a few quick housekeeping reminders. Please do keep your microphones muted and your cameras off during the presentations. The presenters will put their cameras on if possible. The main presentations will be approximately 8 to 10 minutes each, followed by 2 to 5 minutes for questions of clarity. And thereafter, we will have an hour for broader discussion, and we welcome our attendees to contribute to that discussion too. Should you have a question of clarity in the Q&A time, please use the raise hand function or type your question in the chat. And before you speak, please remember to unmute, put your camera on if you're able to, and please do introduce yourself before you ask your question. Without any further delay, I'd like to kick off with our first presentation, and that will be by Anna Grimsrud. Anna is the Senior Technical Advisor at IAS, the International AIDS Society. Within the HIV Programs and Advocacy Department, she holds a master's and PhD from the University of Cape Town. And prior to joining IAS, Anna worked at the Treatment Action Campaign, TAC, and UCT, and as a collaborator with the Desmond Tutu Health Foundation and MSF. She has led various projects funded by the Canadian Institutes of Health Research, the Global Fund, and Bill and Melinda Gates Foundation. And Anna is also deputy editor at the Journal of the International AIDS Society and serves on a number of national, regional, and global technical working groups on HIV. We look forward to hearing from you, Anna. Over to you.
There we go. I'm going to just say thank you to Nisha and her colleagues for the invitation today, and really give a real whirlwind tour here, focusing on differentiated service delivery, primarily for HIV in South Africa. Also, given the audience today, I think that many of you are really intimately involved in the implementation and research sides of DSD for HIV treatment. So I'm going to dive in quite quickly and really looking forward to the thoughts and discussions both following the presentation, but also in the second half of this meeting. So to start off, I'm going to give you a little bit of an overview of the DSD story so we can see where we are. And as was said at the beginning, I work at IAS, the International AIDS Society, and we've been involved in differentiated service delivery for the last 8 years or so, kind of looking at how to advance the agenda forward and spending a lot of our time on the operationalization of DSD, supporting both countries and researchers and civil society to get more involved. So for many of you, the DSD journey will have started around 2015, and we like to think of this as defining and building the DSD community, of which many of you are a part of. And this involved important steps such as developing the building blocks of service delivery, and also really pushing forward this idea that you could have different mechanisms, different options in terms of these building blocks for clinical visits compared to ART refills. We then quickly moved into a second chapter of DSD, which we talk about as riding the wave. And in addition to kind of having different areas in which people thought about differentiated service delivery, so not just for treatment, for example, for testing and for specific populations, we saw real endorsement of differentiated service delivery by our global funding agencies in the HIV response. And this enabled many of our country colleagues from around the region to implement and start to scale differentiated service delivery. Chapter 3 is really what I think of as where we are today in terms of responding and adapting to COVID-19. And we've learned a number of lessons in terms of how treatment programs were resilient during the last couple of years. And so I'm going to start today by talking about these kind of areas and where we saw adaptations in terms of the eligibility for who could access DSD for HIV treatment models, the reality that we extended treatment refills and clinical consultations for many people. And there was a renewed emphasis on shifting or transitioning people to out of facility or community-based models, as well as some momentum around integration. So starting first with the eligibility piece, This is a slide taken from PEPFAR colleagues, and PEPFAR has really kind of pushed the envelope in terms of expanding who could access multi-month dispensing. This is important because previously this had been something that was only really allowed for people who were clinically stable. And with COVID, we saw that there was an acceleration of really trying to prioritize access to uninterrupted treatment for all populations. We also saw that this related then to updates to WHO guidance in 2021 that came out around changing who was stable or who was defined as eligible in terms of their clinical stability. So we saw a reduction in the time needed to be on treatment, the formal inclusion of pregnant women, again, formal inclusion of children and adolescents being supported, and that this is something that could happen for anyone regardless of what regimen they were on, thanks to new research in this area, and less restrictions regarding evidence of treatment success. So a reduction from 2 consecutive viral loads to 1. And so this really highlights how we've been changing who can access DSD. We also saw in the WHO guidance an articulation of 4 general models of DSD for HIV treatment. So as was mentioned in the beginning, there's often confusing language and confusing terms. And so this articulation of these 4 model types helps us understand and compare and contrast between different models. So we have group models, and for group models, we can think of those that are facilitated by a healthcare worker, and this could be a lay worker or a clinician. And then we've got models that are managed by people living with HIV themselves. And for both of these models, they could take place in facilities or outside of facilities in community locations. And then we have individual models, so those that are at our health facilities and those that are more broadly within our communities. And so you see here with this advancement on my slide, I've taken from both the Western Cape policy in 2018 and South Africa's national adherence guidance, the different models that are available in South Africa and kind of put them into these 4 buckets. And so I think this kind of nomenclature, again, allows us to understand and compare and contrast when appropriate. We've also seen from the PEPFAR data a real acceleration of multi-month dispensing, and this is obviously related to that relaxation in terms of who's eligible, but also emphasis on this. So this is data from 21 PEPFAR-supported countries, and importantly, this excludes South Africa. And you'll see by the end of last year in the red, the number of people who received 6 months of drugs, and in the kind of teal or blue color, the number of people receiving 3 to 5 months. And so this is now over 80% of the cohort of PEPFAR-supported countries are receiving at least 3 months of supply. And I want to pause here, and I'll bring it up again later, but just to say how much progress there's been made in countries near South Africa in regards to extending ART refills. This extension has also been seen among children and adolescents, or those under the age of 15 years. So again, this is the same figure, just restricted to that age group. And again, 60% of children and adolescents in 21 countries that are supported by PEPFAR are receiving multi-month dispensing of beyond 3 months. And so these are just a good example of something that maybe South Africa could learn or understand in terms of how these countries made this possible. We have seen in South Africa that there were emergency provisions put in place to extend those who had 6-month scripts to have 12-month scripts. And some of the data that we have through the CCMDD mechanism highlights that there were 1.5 million people who received 12-month scripting during COVID, 1 million of these being those receiving treatment for HIV, and another 200,000 for those receiving HIV treatment and another chronic medication. And so this is one of the ways in which we'll come back to South Africa is really leading in terms of extending its clinical consultation frequency to once a year. So these people would receive their treatment refills more frequently, but they would see a clinical consultation for a comprehensive visit once a year. And again, this highlights that separation between how someone collects their treatment refills from how someone receives their clinical care. And so we always want to kind of separate out those 2 pieces. We also see, as an evidenced by South Africa, but we've seen this globally as well, this push in COVID to community or out of facility models. And so again, here, this is some CCMDD data that highlights how in blue, the external pickup or collection in an individual model outside of health facilities is the one that went up between 2020 and the end of earlier this year. We've put together some policy dashboards that really highlight the different areas within DSD for HIV treatment and where different countries are. And I wanted to kind of share these in certain places in this presentation. So here you'll see that there is some policy support for integration of non-communicable disease refills within DSD models. But really, in most countries on the far left-hand side, you'll see that this isn't specified, meaning that in their DSD guidance or in their NCD guidance, they're not talking about how to do NCD refills and alignment within DSD for HIV treatment models. And I highlight South Africa here as clearly this is one of the areas that South Africa is leading on given our integrated approach. As Nisha mentioned, a number of you on the call today are part of a DSD research collaborative, and this is really a group that meets on roughly a quarterly basis to try and understand what the gaps are and where we could work together to fill those gaps and then accelerate the time from having the research and the evidence generated to the implementation. If this is a group that you're interested in joining, please feel free to get in touch with me later today or after the call on email. But this group met earlier this week and we talked about those three areas again, so that maybe during COVID, we would have some data from programmatic rollout that would show these COVID adaptations and their impact on people living with HIV. But we think there's still some gaps. So there's still some gaps for those who are viremic and maybe were fast-tracked into DSD models. And there are also some gaps for those who are pregnant and breastfeeding. And within the context of South Africa, I've added this little question here around whether or not we really have integration and differentiated service delivery happening in postnatal care. We also have an evidence gap around 12-month clinical visits. And we really don't have a lot of data on how to, or the outcomes of when there is integration, particularly of non-communicable disease treatment within our DSD for HIV treatment models. In addition to those areas from COVID adaptations, we've also highlighted these areas as gaps. And so I'm hoping this is something our discussants can pick up in the second half of the hour. And I'll go through a few more of these in detail where I think that South Africa maybe has a unique opportunity to contribute. And so this is where I think we are, right, in terms of chapter 4 and building on the resilience from COVID. And I want to now focus on some uniquely South African opportunities. So here's the laundry list where South Africa is leading the way. So we know and we've seen the integration with common NCDs, and I'll talk through that a bit more. We also have a great policy environment in terms of enabling group and community models in addition to that integration. We see a large cohort in external models, so in community-based individual models. And part of that has been enabled through a scaled partnership that we have with private pharmacies. And in South Africa, what's unique there is that it's done without a co-payment from the person living with HIV. So that is rare. And we see in other countries a shift to doing integration or leveraging private pharmacies, but often with a co-payment. We do have people who are having annual clinical consultations. This has been the policy for a while in the Western Cape. And like I presented, there was some movement on this nationally in terms of emergency restrictions. And in South Africa, we also have a great policy around re-engagement and differentiating service delivery at the point of returning to care. And then we're also leading the way in terms of considering and thinking about when to do viral load, both in terms of the first viral load following ART initiation, as well as viral load for those who are re-engaging. So I'll go into this a little bit more detail and talk about the ways in which I think our routine data systems could help us. So as I said, here's this graph in a different way. So this is a new one, actually, it looks the same. So in the blue, you've got people who are receiving their HIV treatment through CCMDD. In red, those getting their HIV treatment and other, and in green, those chronic meds. And again, this is just to highlight how much integration is actually happening in South Africa. But we'd love to have some more data that could help us understand what the outcomes are for those who are living with HIV and another chronic condition. And we'd also like to understand more about this control continuum. So knowing that these people are clinically stable when they enter these models, how does that relate to their ongoing outcomes? We also would like to understand the coverage, particularly with those with common non-communicable diseases. We have a good idea of coverage for HIV, but maybe less so for diabetes and hypertension. And we don't have this data broken down by type of model. So we don't know if these people are in adherence clubs, external pickup points, facility pickup points, et cetera. We also see from some recent CCMDD data that this has been scaled in a number of places. And so most of us will be familiar with this map of South Africa. And you can see that in some areas of the country, particularly in Gauteng and KZN, a real density around external pickup points in terms of the proportion of people who are in these models. But we see far fewer of them in places like the Eastern Cape. So our question here would be to try and understand what the impact is of this external pickup point being scaled up, and as well to put some focus back on adherence clubs, many of that were dissolved during COVID, and whether or not that model is something that should be reinvested in. And then also we'd like to understand the outcomes for our younger populations who've also recently been supported to be shifted to external pickup points. As mentioned, we've got 12-month scripting that was an emergency provision, and we have had these policies in place. So on the left, you'll see an excerpt from the adherence guidelines saying that clinically stable patients are required to see a clinician once a year. And in the Western Cape, that this has been policy since 2018. So here we're really looking for South Africa to provide us with guidance on how this works and if this is an okay thing to do so that we can support other countries to do it. We also want to understand the cost implications of this. So if people are coming less frequently to the facilities, how does that relate both to provider and recipient of care costs? And then also some of our data systems only really track people in real time when they come for clinical consultations. So we also do want to understand what is happening to these individuals in between their 12-month clinical visits. Here you can see again another one of these policy dashboards, and just to highlight that South Africa again is one of the only countries that has the 6 or 12 monthly or annual clinic visits. And so this is a real opportunity for us to shine a light and share evidence globally. Conversely, here's us on the treatment duration or the multi-month dispensing, and you'll see here, unfortunately, we're all the way over on the left-hand side. So would really like to understand how we can support multi-month dispensing in South Africa. Onto re-engagement, here's some screen grabs from the National Adherence Guidelines on this relatively new SOP 9. And important here is to understand and see that there are different options for people based on how long they've interrupted and whether or not they're well or clinically unwell. And so we really need more data in this area to assess how long people have interrupted before they come back and what their outcomes are, how it works in terms of the timing for their viral load, and really looking at their outcomes following re-engagement, and if we are able to accelerate access back to multi-month dispensing and back to differentiated service delivery or our repeat prescription collection strategies for those who are re-engaging in care. This is my second to last slide on just some more opportunities ahead. So I want to talk a little bit more and hear from the group around whether or not we're going to invest in these group models. We're also excited about opportunities for differentiated service delivery and PrEP in South Africa. And again, we do want to look at integration beyond just non-communicable diseases, but also to contraceptive care commodities. So understanding what our coverage is of contraceptive care for those in these models and how to support longer acting reversible and injectables versus oral for those women who want those options. I'm going to leave with this slide, which is the priority indicators for differentiated service delivery that Nathan and his colleagues published earlier this year in terms of the SI guidance, and say that globally, this is what WHO is recommending. All of these are priority indicators. So the idea is that countries can report on the proportion in receiving 3 months of treatment or more, on the uptake, on the coverage, on the retention within these models, and on the proportion that are virally suppressed. And so I feel like this was my clothing side in terms of us being kind of optimistic and looking ahead for where we should be going here in South Africa. Thanks, Nisha. I'll stop there, and apologies for speaking so quickly.
Thank you very much, Anna. That was a really fantastic overview of DSD, gave us nice perspective and a good way to start off the session by giving us so much background and what to think around in terms of routine data. So thank you very much. Do we have any questions of clarity for Anna? We have about 2 to 5 minutes for brief questions of clarity before our broader discussion in the second part of the session. So there's a comment from Natasha Berkowitz in City of Cape Town in the chat. And Natasha and her team did a small study on NCD and art integration in clubs a few years ago. And they found that clubs didn't worsen the NCD outcomes, but NCDs weren't necessarily controlled on entry into the club. And Diane Abrams is busy with a dissertation on NCD and art clubs, so we should be getting some more data soon. So thanks for that comment, Natasha. And if you do have the link to the study, please do add it into the chat for those who are interested. Are there any other questions of clarity? Okay, colleagues, and in the interest of time, I think we will move on to our next speaker, who's extremely busy. We've managed to catch her on a very busy day, but I'd like to welcome Romy Fritz. Romy Fritz is a senior technical advisor at the National Department of Health and has worked in the National HIV, AIDS and STI program since 2015. She has a qualification in actuarial science and mathematical statistics and has largely been focused on monitoring and evaluation in the HIV program space over the last 13 years. She's currently the lead of Operation Phuthuma, an NDOH initiative to accelerate performance towards the 95-95-95 targets. I'll hand over to you, Romy.
Thanks, Nisha, and good afternoon, everyone. Nisha, I just want to check that you can hear me okay, because I am sitting in the training room.
Yes, we can hear you just fine.
Okay. I'm not actually going to put my camera on just because we are in a training venue, so it's not going to work very well. But if I can then share my screen from my side.
Yes, go ahead.
I caught the end of Anna's presentation, and so afternoon, everybody. And I realized that Anna and I work largely with the same people in South Africa, so we've got some of the same slides, but that's okay. I hope I'm not going to duplicate anything that she already presented. But I think together we'll kind of provide enough insight into what's happening in South Africa. So in terms of differentiated models of care, of course, we know that there is at the global level, we refer to it as DSD, or differentiated service delivery. In South Africa, we've made a deliberate move to refer to it as DMOC. The decision was made in 2020, really just to not cause any confusions and be specific about linking to these models of care. I'm also conscious of time, so not going to spend too much time on things we know. There are underlying policies, guidelines, and SOPs. I heard Anna mention SOP 9. That's quite new on the adherence guidelines. But of course, everything that we do in terms of DMOC is framed by our guidelines, our policies, and our SOPs. As I think Anna would have mentioned, there is still work to be done on these, and we're not saying that they're by any means finalized. As we implement, as we scale, we're also picking up issues that they need to be addressed in some of these SOPs. So we continue to improve that. Just sort of basic overview, and again, I'm not sure, a lot of these come from recent meetings, so Anna might have had them in the sessions in her presentation also, but we are also focusing on differentiated models from a testing perspective, as well as in terms of supporting our adherence guidelines. So for certain populations, obviously index testing becomes quite key because it helps us identify some population groups that may not necessarily be accessing our facilities. Targeted testing and key entry points. So that's something we specifically are focusing on for pediatrics to make sure that we are testing, for example, in our EPI and IMCI clinics or rooms in our facilities. HIV self-screening is really a strategy that we've adopted. It seems to be most successful, and we're trying to sort of scale it up, particularly amongst adult men. And then, of course, with that goes active and successful linkage to care. And even within that space, we're finding that different population groups have different needs in terms of that linkage. From a treatment perspective, I mean, I think we know much of this. So again, there's specific interventions focused at children. There's the conventional sort of model or standard care that we look at. So that includes the same-day initiation, which has been introduced for a while, and also our community art initiation, which is really now targeting main key populations in our adolescent groups. We've got repeat prescription collection strategies, which we've spoken about. I saw Anna had some CCMDD slides as well. And so those are the kinds of things that we're using to address the gaps and the needs for each of our population groups. Within the Welcome Back campaign, or the Back to Care sort of strategy, we're looking at how do we reduce loss to follow-up? What is really the mechanism or the vehicle that we need to use for particular groups to address their adherence issues in a meaningful way? So at the sort of global level, we're part of the Sequin network. This is the most recent Sequin dashboard that was completed. So you can see that we're monitoring against policies, guidelines. There's a whole list. And essentially the measures tried to get a sense of how far along in that process we are. You can see that as the years have progressed, we've gotten more and more green, which is encouraging. But the last little bit that's really outstanding is looking at the impact. So looking at, you know, despite the improvement that we've made, a lot of what we've done so far is kind of setting up the foundation. Now we're at a very heavy implementation stage. And so we need to make sure that what we're doing and what we've set up before is actually going to have the impact that we need it to have. I'm sure this was covered. So this is some idea of our current model mix. And up until October to December 2021, I'm going to show you a little bit of data now that gives us a more recent estimate or a more recent value by province. But our target is actually the split that you can see on the right-hand side. This is fairly similar to the new targets that we're setting up for the new financial year. But of course, we're steadily trying to move patients into models that make more sense for them from an adherence perspective. So, sorry. So this is the most recent data that we've had available. It may have been presented as well. So we've got some information off tier.net about which of the three models or which of the three sort of mechanisms patients have chosen. So as of the end of Q2, South Africa's decanted just over 2.3 million stable patients into some differentiated model of care. It's not quite where we'd like it to be halfway through our, we're kind of on track. We're finding though that the decanting works almost kind of in batches. And so we'd be interested to see kind of how that plays out across the rest of the financial year. And although each patient really has the opportunity to select the model that suits them, it's interesting to see that most patients have been decanted to the external pickup points. A lot of that happened. So we found a really significant increase in that during the COVID years, because obviously our facilities weren't as accessible. Adherence clubs where people sit around in groups were not really being encouraged. And so our external pickup points really, the coverage in terms of the external pickup points increased dramatically over those 2 years. And we continue to see that trend continuing. These slides I did see in Anna's deck, so I'm not going to spend too much time on it. So they're based on the CCMDD program, which you know in the sort of public domain is referred to as Double Up Meds. So really just to see that we have 2.6 million active patients. We continue to monitor this on a weekly basis, or well, actually on a monthly basis now with our CCMDD colleagues to understand also not only what's happening in terms of active patients, but also what's happening in terms of the dormant patients. We're finding that a lot of them are kind of being returned to facilities, or they are returning to facilities to have their treatment and particularly their medication managed there. And of course, that's not necessarily something that we want to see. We don't want to see the return of patients who were previously registered on CCMDD. We've had a significant expansion in terms of the pickup points. And the intention is to continue to expand. You can see certain provinces where this has taken off. I mean, we know that in the Western Cape, it isn't something that we really look at in terms of CCMDD, but you can also see the challenges in the Northern Cape as well. You know, we're finding that external pickup points in areas that are more rural are actually not really well received. Or not well, there isn't a lot of uptake for it. And it makes sense, you know, in rural areas, people actually prefer to go to the clinics. And so they prefer to go to the clinic and engage there so we're struggling with the external pickup points in our more rural provinces. Of course, around our metros, you can see COJ, you can see eThekwini on the Durban. You can see that that's where the concentration of our external pickup points really sits. On average, I mean, we're looking at about 556 patients per facility with per pickup point. And, you know, that varies quite significantly across province again. As we scale up on the pickup points, those averages tend to shift around. Just my last slide is actually just showing, well, second last slide, just the condition split. I know that, you know, we talk about in South Africa, the focus in terms of DMARC has largely been around the patients that are currently on ARVs within the HIV program, but we are also starting to see a significant sort of increase on the patients that are being serviced through CCMDD in the NCD program. So a lot more patients who have comorbidities, and of course, a mix between comorbidities and HIV. So in terms of next steps or way forward, as I mentioned earlier, we do need to continue to refine and develop the SOPs to support implementation. These also need to be further refined as we get to provinces and districts, because there are some nuances in each of our provinces that are a little bit different. We're in the process of target setting at the moment. So over the next couple of weeks and essentially running through to the end of this financial year, we'll finalize this process of setting targets for each of the models. And with that, obviously make sure that we're looking at the projection for what we anticipate happening over the next couple of years. Within Operation Putuma, so DMOC is a very significant piece of what we're looking at in Operation Putuma. We're reviewing tools to support a quality improvement approach around differentiated models of care. Because again, at the end of the day, it's not really just about the number. It's also about making sure that we're driving improvement while we're implementing these models and implementing this process. One of the things that you would have seen it actually in our Sequin dashboard, the M&E systems are in place at the moment, but to be honest, we haven't really started using the data in a way where we can do detailed analytics on it to support the program implementation. That's a fairly recent development. And so it's fairly new in our space. We'll continue to kind of move forward with that and strengthen that process. I know I've spoken very briefly, but I also realized I was late and that there was some content that was covered in Anna's presentation. So Nisha, I'm going to stop there and just ask if there's anything further that colleagues want to ask, if there's something specific. I know I'm here kind of speaking on behalf of some of the work we're doing at National, so I might not have covered everything. If there's anything specific that colleagues need to know, please, if we can have those discussions now. Thanks, Nisha.
Thank you very much, Romy. That was a very clear overview from a national perspective. And we also recognize that Romy is on her way in the midst of travel at the moment as well. So we're very grateful for your time. However, this does mean that Romy may need to drop off the call shortly and hopefully join a bit later. So if you do have any questions for Romy, it would be good to just mention those now. So do we have any questions? I don't see any in the chat, but do we have any other questions? I see Beth and Carol have asked, one slide referred to tier.net data. Is this routine data? In which case is City Health included? Or is it indeed just tier.net data?
So it's a combination. It's not just City. So my understanding is the data that comes out of the Western Cape is a mix of tier data. It shouldn't actually just say tier.net. I'll clarify that for you, Beth, and just come back to you though to confirm that.
Thanks, Romy. Colleagues, are there any other questions of clarity for Romy? So Vanessa has just clarified that PHTC combines all data sources and then imports into tier. So it should be included. Thanks for clarifying.
Thanks, Vanessa.
Are there any other questions for Romy? Romy, I wondered if you could just comment a bit more on the contextual differences between provinces.
Sure. So I think, in terms of I think one of the things that we haven't really done at this point in time is really tailored the models for each specific province. So even as we're going around in provinces, we talk adherence clubs, we talk external pickup points, we talk the facility pickup points, but I mean, these things also work a little bit differently everywhere that you go. And so I'm just watching some of the comments in the chat. And so there is definitely a difference in how these things are being implemented. A very good example is, for example, the thing I was saying about Northern Cape. We're finding that in rural areas, facility pickup points and adherence clubs are the things that most patients actually choose. The external pickup points really don't seem to be taking off in the Northern Cape. And as much as we've tried to prioritize that for the Northern Cape over the last, at least for a year in the Operation Putuma meetings working with the CCMDD colleagues, it's a very slow uptake. And it's not necessarily because Northern Cape are not on board with something like CCMDD. It's actually that practically the way things are set up, it just works better for some patients to be in the facilities in the Northern Cape. It's also a very different context because the patient numbers in the Northern Cape are very different. So that tailoring for each province and their specifics, and then of course getting down to a district level where even further tailoring is required, is the stuff that we're kind of figuring out now. And each province and each district is working to tailor that for their specific population groups. In terms of implementation, I would say in terms of the DMOC models, definitely we found some provinces pick things up quicker than others. We generally find that areas where we have some partner support, things happen a lot smoother. We've got some additional resources and that sort of thing. And that's where we really need to start thinking about some of the sustainability issues. Our metros work very differently to our other districts as well, obviously because of population concentration in certain areas, and there you'll find many pickup points and maybe fewer adherence clubs, that kind of thing. So yeah, each province comes with its own context and its own set of challenges and opportunities, Nisha, you're right.
Thanks very much, Romy. I see we have 2 questions and 1 hand up, and I'd be keen to have you answer them if you're able to, since you're going to drop off, but I'll be guided by you in case you need to run.
We can.
Okay, great. Thank you. Vanessa Moodley has just asked if you could explain how the annual target is calculated.
So the way that the targets are calculated for DMOC, and let me just say, I haven't done these calculations myself, but this is the principle that we've adopted, is that it's a percentage of the stable patients for each of the provinces. So it's based on a percentage. So you can see obviously KZN and Gauteng are going to be the highest numbers, but it also looks at a percentage of only stable patients at this stage, not necessarily the full TROA number. With that, in terms of the stable patients, we use some assumptions to do that. We're not looking necessarily at the lab data to do that. So just a little bit of a disclaimer. So we do look at our TROA number and work on a percentage of that for each province. I saw Jogan asked a question about whether the slides will be shared. I'm happy to share these slides with you, Nisha, for circulation. And
Thanks,
then
Romy.
I'm checking.
So Genchi has just asked
Yes.
about how do the tier.net and sync data compare to each other at the national level? Do they give similar numbers or are there big differences? And just to follow up on that, the reason for asking that is wondering how reliable you think the data in tier is regarding the different CCMDD modalities.
Yeah.
And sync should capture this perfectly, whereas tier may not be so reliable.
Yeah. So and I think this is one of the, I know I saw Lynn and others on the call as well, but this is one of the things that I think we do need to get right. So CCMDD is really just the distribution channel. The models, the DMOC models actually can be serviced, let me say, through CCMDD or through the facilities or through kind of DOH public sector channels as well. So just to clarify that that adherence clubs external pickup points are not models, components of CCMDD. It kind of works the other way around. And for that reason, what you'll get off sync is very accurate CCMDD data. But what you don't get off sync is the data that talks to broader DMOC models that are not serviced through CCMDD. That's the part that I was saying is actually quite new. So we've only recently actually gotten access to data from TIER on the models that people select at patient level. And that's the data that we're looking at now. So this isn't actually sync data. It's very early days. We've just started being able to really look at the TIER data and analyze it. The sync data for CCMDD has been available and is very accurate. So we've been using that for a long time. Beth's asking the percentage. Beth, I'm going to have to come back to you on that. I don't have it with me. I will, when I join the call later on, I'll give you specifics on what those percentages are.
Thanks,
So
Romy.
thanks for the question. I'll make sure that I address that later before the end of the meeting.
Thanks, Romy. And Jürgen has his hand up. Go for it, Jürgen.
Nisha, thanks very much. And thanks to Anna and Romy. It's if we accept that the TROA number has stalled, that we're not really putting new patients or additional patients on treatment and keeping them on treatment. Is there any evidence from anybody on the call on is that real? What are the causes? Is it a data problem? You know, the reason I'm asking this, Nisha, is because is there any evidence that lack of support of patients who've been initiated is causing them to fall off after 3-6 months, and that, you know, the only people that are re-engaging with the system are those folk, and we aren't really spending a lot of time engaging naive patients and getting them on treatment. Now I'm just trying to understand this stalling of TROA, and is there any evidence from anybody about what they think is happening? Thanks, over.
Thank you very much, Jürgen. Romy, I'm going to give you a chance just to respond to that. And colleagues, I think that's also something to think about for our broader discussion as well, because there are many who are involved in DSD research who may be able to provide some insights. So Romy, over to you.
I would actually be very interested to hear some of the sort of the findings from, particularly from the researchers, because I think this is a question that we're really grappling with. My sense is actually exactly as Jürgen said, that we're not necessarily engaging with the naive patients, and what we've ended up doing is kind of recycling. So even with the CCMD dormant patients, as I was saying, you know, you'd almost think that they're dormant because maybe there's been some complication or something like that, but actually we're finding that there may be a combination of treatment interrupters, and then they come back into the system and start as new on art. And so they don't even end up on lists for decanting, because they're classified as new on art. And so there's definitely a lot of work to be done in that space. I'd be very interested to hear if there's anyone else on the call that has some findings or data on that.
Great, thank you, Romy. I don't see any further questions or hands, so perhaps we can discuss that a little bit more during the discussion time when people have had a chance to think around it. And just to note that Jenchi has commented that thank you for your response, and it would be great to link Tier and sync more. So if there are no further questions for Romy, I just want to say a very big thank you, Romy, for joining us on this very busy day, and we will hopefully see you back again during the discussion a bit later.
Thanks, Nisha. I'm making my way to the airport, and then I'll rejoin when I get there. Thank you.
Thanks, Romy.
Thanks, all.
So colleagues, moving on now from the national perspective, we're going to move over to a provincial overview of DSD. And our next speaker is Andrea Mendelsohn. Andrea is a family physician with extensive community health and HIV/TB experience. She completed her medical and public health training at Tufts University School of Medicine in Boston, and she and her family relocated to Cape Town in 2015. Andrea's worked for the Western Cape Department of Health in primary healthcare services since 2017, so we're looking forward to some frontline experiences from Andrea. Over to you, Andrea. You're just on mute, but we can see you.
Okay, I'm just saying hello. I'm going to turn off my video because my connection is not great. All right, let me share my screen. All right, I was asked to talk a little bit more about the sort of qualitative clinician's perspective on some of the differentiated models of care that are being implemented in the Western Cape. So this is more of a qualitative overview of what some of the programs are trying. Oh, there we go. Okay, so why are differential models of care beneficial? I mean, firstly, from the clinician's perspective, it's not a secret that most primary healthcare facilities are overloaded with chronic disease patients. And by that, I mean both HIV patients and non-communicable disease patients. And so clinicians and program designers are really struggling with the idea of how can we most efficiently use limited resources on the patients that need intensive intervention or treatment programs the most, while still keeping those stable patients on care. So it's both a sort of utilitarian intervention, as well as actually what makes sense to sort of use what limited resources you have on those that are most in need. And also from a clinician's perspective, I mean, people don't like trying to rush through volume as quickly as possible. So in terms of clinician morale, ideally, if you have more time to spend for each patient, you'll feel like you are doing a better job, probably will be doing a better job, and have more job satisfaction and staff retention. From the patient's perspective, most of these things have been alluded to in the data. Everyone knows from ART data that people who are stable do better, have better adherence when they're put into clubs or differentiated models of care, because it's more convenient. They don't have to take time off work. They don't have to sit in long queues like the ones pictured below. And it just makes it easier to be adherent. It's more patient friendly in general. And as COVID showed us, actually, there also is infection control benefit to decongesting crowded clinics and allowing the people who don't need to be there to stay in the community as well, while still staying on their treatment, especially well patients and elderly patients who really don't have a reason to come to clinics other than to sort of as a medication pickup point. Okay. So then you could say which of these chronic patients, and again, I'm talking about sort of a more integrated perspective of both NCDs and HIV, should be seen and where. So some of the ways that we're starting to think about how to divide up patients is in sort of three models or three groups, let's say. So those are who are well controlled, which is who you think of as traditionally being put into an ART club. Those are sort of moderately controlled and those who are poorly controlled. And there isn't any standardized set of criteria yet or guidelines that have been approved. I wrote down some examples of some of the sort of criteria that we're starting to work with. And some of these criteria wouldn't fit national guidelines perfectly, and we acknowledge that because we're giving clinicians a little bit of leeway, especially with hypertension, to be a little bit more flexible. Say with an elderly patient, it's acceptable for them to have a blood pressure of 142/92 or something like that, as opposed to a young patient who you might want to have be a little bit more aggressive with. So some of the things again, with HIV, it's quite straightforward. Viral load less than 50 in the past 6 months, you can go into an ARV club. But when you start thinking about integration, you need to start thinking again about ways to differentiate stable, moderately controlled, and very poorly controlled patients based on some objective criteria. So for diabetics, A1C is quite convenient. For hypertensives, obviously blood pressure. For asthma, number of EC visits or how frequently you're using a rescue inhaler. Epilepsy, seizure frequency, again, EC visits. There's lots of different conditions that you have to start to grapple with when you have a fully integrated approach. And then what I put is just some examples of a lot of the different models of care that people have mentioned already and where they sort of fit into the picture. And again, like people have talked about e-lockers, ARV clubs, wellness hubs, external pickup points, either at the facility or in the community. So sort of which some people are also calling like quick pickup points or fast lanes. For individual patients and NCDs who aren't in club, we've been trying to implement 12-month clinical visits and with a 6-month medication repeat without the patient present. Group visits, which could be used for well-controlled patients or moderately controlled patients. Also part of this sort of sorting of patients or differentiating patients tries to utilize your clinician resources most effectively. So sorting the sort of moderately controlled patients more to clinical nurse practitioners to allow medical officers to attend to the most poorly controlled patients who might be the most medically complex. And again, frequency of visits, which probably isn't ideal, but is pragmatic based on capacity at facilities. And then again, to try to save your sort of most intensive resources, so things like community-based services and home supports, treatment failure support groups, allied health visits with social workers and dietitians and psychologists for those who are really struggling and need much more intensive intervention. Okay. So a lot of differentiated models of care have already been implemented, but there are a few essential tools that will make them more efficient and actually make them more sustainable for the long run. And some of these are in development, but I just wanted to sort of mention what would really help aid the process and make it sustainable. So the first thing is e-prescription. So for example, the city of Cape Town is ahead of province in this regards, because I know Premise, from what I've been told, does do bulk club printing, and it is something that province is working on, having e-prescribing. But this is really ideal, because right now what happens is a lot of clinical nurse practitioners will spend days just literally rewriting prescription, which is just wasted clinical skill. You don't need someone to just spend hours and hours reboarding medicines. So if you can do if you have e-prescribing that's saved online, so multiple clinicians can look up the same person at different times, update a prescription if it's needed, and print it, and you could print a club all in bulk. So actually even a receptionist could help with the printing, and then the medication, the prescription could be reviewed by a clinician. It'll just make things more efficient and free people's time up for actually high skill activity, as opposed to just administrative tasks. So having a sort of efficient e-prescribing method is would be very beneficial, but going with e-prescribing, it doesn't really do any good to roll out a software if clinicians and admin support staff don't have computers and printers. So basic hardware is necessary to make this implemented, and again, make a differentiated model, care model efficient. There already is 2-month dispensing and some 3-month dispensing. I know up to 6 months has been tested successfully in the research space, but again, this would to standardize longer prescriptions, whether it be 3 months or 6 months, in terms of longer dispensing of medication, would really help both patients out and staff out, because it just is fewer times where the patient has to get to either the pickup point at a facility or an offsite pickup point. So it's improved convenience, which generally translates into improved adherence, as well as staff not having to interact with the patient as frequently, because they only have to come to the facility or the pickup point 4 times a year, or even less ideally. And again, all of this is targeted at patients who have been proven to be stable, doing well, and need less monitoring or intensive intervention. So what data tools would also help implement differentiated models of care? So what the 2 previous speakers have spoken about quite extensively are aggregated data can be used to estimate the percentage of patients that target facility targets or provincial targets for each model. So you can give local feedback at the local level of how people are doing in terms of decanting patients or stable patients into those differentiated models. Dashboards and aggregated reports can also be used to monitor outcomes, to measure the impact of those differentiated models on quality of care and how patients are doing. In terms of one thing that the Provincial Health Data Center is involved in developing at a patient level is using data to develop reports that are actionable and that will improve interventions at the individual level. So some examples of things that are either being used or in development or could be developed that would improve service delivery or assist service delivery are reports that would track key blood results for community-based clubs or cohorts. That way it makes it easy. So right now, often clubs will use a handwritten register that counselors keep track of results to make sure everyone has their annual viral load, for example, and they're still suppressed. So again, line list reports can help do this more quickly. If there are community health workers that are collecting health data at wellness sites or community sites, it's useful to import that data into a central data system. In the Western Cape, we have single patient viewer, but a way to aggregate those blood pressures and eye screens and foot screens that ideally could be collected off-site. Data alerts are being deployed already for some abnormal results, like for example, in the Western case, positive PCR results for HIV positive babies, but it also could be, data alerts could be used to help, again, help community health workers or counselors flag patients who were decanted into community groups who suddenly aren't stable, whose viral load suddenly shot up, or their A1C is very high, and that way they could be recalled more quickly. You can have reports again to track annual bloods and medication repeats, so to keep those calendars that everyone religiously follows, to make it just easier to remind people when prescriptions need to be repeated or bloods need to be drawn for monitoring purposes. Automatic SMS reminders could be successfully implemented to remind people to pick up medication or draw annual bloods. Already automatic SMS reminders are starting to be implemented for TB gene expert results. And finally, actionable line lists for early loss to follow-up patients. So patients who don't collect medications, again, to try to catch those people early in their disengagement in care so that they can be recalled and re-engaged before they have a large treatment interruption, and to get down to sort of the sort of qualitative nitty-gritty of why people are interrupting their treatment. Future tools that would actually very much help, which Anna alluded to. So 12-month prescriptions were implemented to COVID. This has been retracted, at least in the Western Cape, in the sense that patients are still being seen every 12 months, but their prescriptions expire after 6 months. So essentially this creates an administrative nightmare, because there's a lot of wasted administrative time of clinicians literally repeating prescriptions for patients who aren't being seen, for stable patients. So again, nurse practitioners who could be spending more valuable time with patients, admin staff trying to keep track of reboarding calendars and rewriting prescriptions 3-4 times a year, again, to account for festive season holiday jumps. And it is a big barrier to implementation, because there's a lot of clinician and reception staff who don't want to repeat prescriptions or write multiple copies or keep track of it, and just sort of get fed up and say, you know what, I'll just bring the patient back in 6 months or in 5 months, and becomes a real barrier to implementation. So if there were a way for the Pharmacy Council to sort of more permanently approve a 12-month prescription, I do think that would infinitely strengthen a differentiated model care model, in that patients who met clinical criteria and that were eligible for an annual clinical review, which is actually what's happening on the ground anyways, could have a annual prescription that matches that clinical review, which would save a lot of administrative time and free up a lot of valuable clinician time, which is a very scarce resource to actually see patients, and then have more time to engage with patients, so that we don't have these treatment interruptions. Because the same people who would be doing counseling are instead running around trying to get prescriptions and submit them to pharmacy, and spending less time interacting with the patient. So I think we're actually being counterproductive by sticking to a 6-month prescription, even though in reality, we have a 12-month model for stable patients. So one of the limitations of differentiated models of care, I'm a huge fan, I think it's fantastic, but I don't think that it will substitute 100% for a clinic-based model. And one thing is, if you talk about integration, so first of all, HIV patients generally tend to be very stable. So it's the majority of patients that are virally suppressed and could be decanted into clubs. When you talk about NCD patients, if you start having clinical guidelines, only about 1/3 are probably controlled right now. So it is something we need to work on. So that probably about 2/3 of NCD patients fall into that moderate or poorly controlled category. And so it's not, so it's not that decanting decanting the third stable patients will help free up more space and resources for those 2/3 that are uncontrolled. So hopefully we can make a small dent on that and improve control, but it won't, but we won't be able to shift as many to a community-based model in an integrated approach when you extend beyond HIV. And in that case also, to improve a lot of NCD control, we need to focus more on multidisciplinary team efforts beyond clinicians, so include CCWs, counselors, social workers, allied health, psychologists, because a lot of people are really struggling with complex psychosocial and medical problems that contribute to poor adherence and poor outcomes. Additionally, even when these patients are decanted into clubs, they still use the facility for other things. So there's a lot of acute care that's not necessarily taken into account when you talk about decanting clubs. So they might collect their chronic disease medication off-site or from external pickup points, but ARV club patients are still routinely coming back for the things that we're not going to get rid of. So URIs, back pains, anxiety, depression, abdominal pain, medical forms, job forms. So you still need clinician time on the ground at facility, and as well as more serious emergencies and traumas, to essentially be a public health service, right? You still need to increase the capacity on the ground to be able to take care of the ordinary health conditions that we're never going to completely de-escalate, no matter how efficient or ideal our differential models of care are. So I just wanted to end with that note. And again, I'm happy to take any questions now or later on.
Great. Thank you very much, Andrea, for that very comprehensive overview of what the issues are at the front line. I think you've captured that very well, and I'm delighted to see that there's been some active discussion already happening in the chat. In the interest of time, I think we should hold those for the broader discussion and head straight into our final presenter for the afternoon, and then we can discuss all these issues in greater detail. So our last presentation is by Vanessa Timmerman, who has presented at several of our MeSH meetings. Vanessa is a data scientist at the Provincial Health Data Center with a background in biology, epidemiology, and computer science. She has worked in the health informatics and health system strengthening field since 2003 and has experience in both public and private sector. And Vanessa's current focus areas at the PHDC are to support data integration and developing reporting tools. So over to you, Vanessa.
Good afternoon, everybody. Can you see my screen, Nisha?
Yes, we can. You can see you, hear you clearly.
Okay. Just trying to get it in presenter mode here. Sorry, I see it's swapping screens. Just a second. Are you seeing the presenter slides?
Yes, we are seeing the presenter view.
How do I?
So Vanessa, all you do, keep it there, just keep it there, go to display settings. On top, you will see, right, go on top, you will see show taskbar, and then next to it is display settings, right on top.
This one.
On the presenter view with display settings right on top.
Right on top, not at the bottom, on top.
There we go.
Otherwise, okay, let me reshare and then just share the other screen.
Okay.
Okay, is that be seeing full screen now?
Not yet. I don't think it stopped sharing the current one.
Oops,
okay, yes, now we can. Perfect.
Okay.
Now we're seeing code.
Oh my goodness, okay.
Okay, we can see your slides again.
Perfect. Okay, good afternoon, everybody. So I'm just going to go through a bit of our definitions, data trends, new enrollments versus decanting, and then we're going to show just a bit of a Power BI model we've started to build to look into decanting. So we haven't really done a lot of work in this area yet, so it's quite new to us as well, so just bear with us in this area. So the pharmacy data sources that we are currently using are JAC, which is a clinic-based pharmacy for most of the facilities in the province, and then CDU, the chronic dispensing unit, which is for the what we will use as decanting. So the register systems also collect dispensing info, the PHIS system, TIA and premise, as you know it from the Western Cape. But for the purpose of this discussion, I am mostly going to focus just on the pharmacy systems. So we've decided to use CDU as our marker of decanting, since that's usually when the patients are referred to clubs, then the CDU is used to pack the medicines and dispense in that way. So there could be some limitations. So we could have facilities in rural areas or outside of metro, which is not using CDU. So that is a limitation we are aware of. But you'll see soon that CDU do have quite a good penetration. So hopefully we're not missing too much. And then even with registers, we might overcount, since we're not too sure how they handle sometimes when patients are not getting it from clubs. Do they remember to go back to those systems and take off that club name, etc.? So we found this piece of a guideline in terms of decanting who's eligible. And we thought there might have been a timeline on it, but it seems like any patient at the moment who's stable on ART and with a viral load less than 50 copies per mil, and then for your patients with comorbidities, just where there's no drug interactions. So if we look at the CDU and JAC dispensing, so I thought just to give you some sense of the scale and how does the picture look over the past few years. So we can see CDU, the green bars, they have picked up since 2019, stable 2020, 2021. And I think just because we haven't completed this year, that bar is a bit lower. So they probably end up around the same numbers as last year. JAC, we can see, is also slightly decreasing, so maybe a bit of an indication that the decanting started to happen, and that's why we maybe see that difference between the numbers being 2019 and 2020. On this slide, I thought to also just give you a sense per district. So on the left-hand side, CDU, we can see the metro is obviously the biggest one where most of the dispensing is happening for, followed by the Garden Route and Cape Winelands. And then also just that steady increase that we saw in the previous slide for metro and for the others as well. And then JAC, the slight decline over time, but roughly that gives you a sense. If you look at the numbers, so for CDU, we are in the order, if we just look at metro, for instance, in the order of 400,000 dispensings per year. And then on JAC, just above 500,000, it started off and now at 400,000. So roughly, I would say 50-50% distribution between the two dispensing modalities. This is just a pattern to also just more background and to just show you how it looks over time per month breakdown. So we always see around Christmas time the bit of drop that starts to come in and then it picks up, and that's just the Christmas jump that we refer to usually, where they do double dispensings. Interesting enough, I think in 2020, when COVID started, we saw a big drop around August and September. So I'm not too sure if that was just more dispensing. You'll see in the months before July quite a jump there. So maybe it was just to counteract the second, I think, lockdown we had at that stage. Jack, also similar pattern that we can see, a bit of a drop during your December, January, and then mostly steady throughout the year. This is also just to look at the pack size dispensing. So for CDU, we can see that most of the dispensings are in a 2-month format, little bit of 4 months dispensing, but overall basically 1 month in some cases, but the majority is a 56-day dispensing. With Jack, there is a bit more variability, so that the small graph is just to point out the date points or pack sizes that I've picked out for the larger graph. So we can see also mostly 28-day packs in this case, and then the 84-day packs and 112 days. So definitely just a slight difference there between the two systems. Okay. Here we go. All right, then I thought to just have a look a bit. If we say we are dispensing or decanting a bit more, do we open up more opportunities to get more people on board? And we don't see the trend completely at the moment. So this is per month and over the years, just the two modalities. So we're looking at number of patients with CDU dispensing and versus what's a Jack dispensing in that month. And then we plotted just the new patients that started in that month to get a sense of this. And I think the major thing just to note here is from where we started in 2019, it has declined a bit over time, and we're not really up to the same numbers as in 2019, and there is just as we would expect in the December, January, a drop usually, and then it starts to pick up throughout the year. What we can also see then is the decanting is in the order of about 1/3 of all the art dispensing, so that's giving you some idea of dispensing for, and this is speaking to Metro. This is West Coast, so we've done it for all the districts, but I'm just going to show you 2 or 3. So also a similar pattern, bit more volatility, but we are dealing with a smaller scale for the new patients, so don't be too stressed when you see that. We can see a smaller number of people here decanted compared to the previous one, more in the order of, I would say, about 20%. And we'll see that in a moment on the Power BI report as well. What else could we see? Yeah, so I think that's the major thing. And there's just another district also showing you a bit more of the downward trend in terms of the new enrollments. All right, I'm going to jump to the Power BI now. So basically what we started to build a model to use as a management tool probably going forward, and just to see a bit of trends and how is it going per facility and district. So I'm just going to show you that, and the focus or angles that we thought to have a look at is the viral load status and the in-care status, and bringing those 3 aspects together in the data. And what we start off with a long table. So long table, we just refer to, we log every visit for the patient, and then we decide, okay, we want to cut the data off at a certain time point, and then we get the last record for every person up until that time point to get a snapshot almost of how it looked at that point in time. And that's the data set I'm using in the Power BI. Just going to get out of this one. All right. I'm just going to switch off my camera because I'm on the other screen now. All right, so just quickly overview status. We're just double checking if our data is making sense, for instance, and I'm switching, say, to a R naive group, and then we can see no decanting is picked up. So that makes perfectly sense in how we've grouped the data. I'm not going to go into any of this. That's not really what we're looking into today. But let's say we look at the art group, then we start to have a look at so this data set, we've decided to cut off on the 30th of June this year, just because we have to allow about 3 months for all the tier dispatches coming in from rural. So it's not 100% up to date. So I didn't want to skew the data by the last 3 months. So at the time point when we cut off, we look at the patient's last art in hand date, and then we just have a look at what is their in-care status. So about 66% of that data set of patients is 462,000 patients. At art, we're still in care or just out of care by 28 days at June, end of June. The median in-care period is just people who fell out of care between 28 and 90 days before 30th of June. Longer in-care period is just between 91 and 365 days. And if you haven't had art for more than a year, then we've put you in an out-of-care group, basically. So we'll see this in a moment. We're going to use a slider, basically, instead of the categories. And then one can use that as a mechanism to look at the data. And then at that point, when we cut the data off for each patient, we just work out then were they a decanted patient at that stage. So if they've never received medicine from CDU, we just put you in the never category. If they at that point had a CDU dispensing, we say you're currently a decanted patient. Or if we can see previously you did have dispensings from CDU, but the last one was maybe not, then we've just marked you as a previously dispensed patient. This is just a little bit of an overview. So the 100% is here, so it's row totals. And here's just to get a sense of per district, how does the dispensing pattern look for this data set. And we can see Garden Routes doing quite well with around 39%. The Metro, there's 31%, and we could also see it on that bar graph with all the green pieces around a third of the bars. Central Karoo, 42%, Winans 22%, West Coast 20%. So quite a bit of a range going on here. Viral loads, then we look at the viral load status for that patient at that endpoint when we cut off. And we can see most of the people are in the suppressed viral load in the window period. We've used the 18 months in this case. Another suppressed viral load, which is outside of the window period, another 14%. 7% detectable within the 18 months, 3% outside of it, and 9% without a viral load. So this page is where a lot of magic happens, I guess, for managers just to play around with a bit of scenarios and see how the picture changes. So I'm going to start off by just saying include everybody. So everybody in the data set, either if you're in care, out of care, so that just gives us the starting picture. So based on that set, we can see that about 47% was never decanted, and then our current decanted group is 30%, and then 22% for previously. For that group, again, we look at I've made the viral load suppress, the green bar, so we can basically count these all together. So that's almost in the order of 80%, and then some of the undetectables and the low viral load. Then we've got the patients grouped just by the 3 categories also, and in their respective viral load categories. So that's also just giving us some sense of it. So the next thing I'm going to do is change the care status. So if we bring it down to we can either slide it or type it in here. So that's people who've been in care within the year at the 30th of June. So we can see how the picture changes basically. The things, just going to slide it slowly, then you'll see how the yellow, bar chart starts to change into the percentages and things. So let's go to people who've been in care recent. So usually services would use the 90-day marker as a in care status, and that gives us some idea of the currently decanted. So that's about 36% of people who's currently in a decanting position. If we look at the viral load suppression, we can see also close to 82, 83%, a little bit extra 5%. So that gives us a good idea. So what we see here is the months of art start. So if I bring this now down to say a recent art starter, so let's say 6 months, people have started art in the past 6 months, this changes the picture quite a bit, and I think as one would expect it. So now you would see a much smaller group of people who's currently getting a decanted model of art. Their viral load suppression is down to 47, so it explains that some of them are probably not yet stable. And then we can just see in these bars also where they lie sort of in the viral load distribution. So I think that this is just a way that we thought might be useful to see the impact of playing with some of these parameters and to check, are we following our guidelines and things. So if I go back, sorry, just to 3 months, people with 3 months on art, we do see some people that's already decanted. So those might be ones we just need to look into and make sure everything is fine, and are they fine to be decanted. But that's for maybe a data cross check and also just facility spot check to see if the decanting was applied correctly. The next one,
Vanessa,
more, yes.
I think we need to wrap up just so that we have enough time for a bit of a discussion. So could we maybe just finish off fairly soon, and then maybe we can go back to the demo as people request?
Sure. I'm just going to show you the other two, but I'm not going to go into detail, so that's perfect. So this is just, we just did it on different layers sort of in the data. So one can go into a metro layer, and you can drill down further. Those are the sub-districts, but it can go down to facility level. So then you can see per facility, how do they compare. So yeah, we can see a facility False Bay that's got quite a big chunk of people who were previously decanted. So, and that there's a facility that's doing quite well. So this is just a nice way, I think, to easily try and see a pattern in the data. So that's all from me, Nisha.
Thanks very much, Vanessa, and apologies for interrupting you.
No.
Colleagues, I think our speakers have really given us a lot of food for thought. Thanks very much, Vanessa, for that, and for the demo as well. That was fantastic to actually see the practical use of data that we can actually make use of in the services. So unfortunately, as originally scheduled, Juanita Aronsa, who was scheduled to chair the discussion today, has sent her apologies, but Andrew Bull has kindly stepped in for Juanita to chair the discussion. And Andrew, likely needing no introduction, is a public health medicine specialist with the Western Cape Provincial Department of Health and currently provides oversight for the Provincial Health Data Centre and has a long-standing involvement in routine HIV data. Andrew will be joined in the discussion by Carol Cragg and Beth Harley and Nathan Ford, and I'll just briefly introduce them. So Dr. Carol Cragg is a medical doctor, with a master's in public health and BSc honors in computer science. And she's worked in the Western Cape Department of Health since 1990 in various facilities. And from the mid-1990s, Carol has been involved with HIV and TB services, initially as a clinician, and for several years as the HAST MO for the Kailicha Eastern substructure. And since 2015, she's been working in health programs, now renamed as Services Priorities Coordination. And Carol's focus has been on clinical governance projects, specifically coordinating the development of clinical governance evaluation. And I think you can see from Carol's various comments, her different areas of involvement and insight into these areas. Carol is joined by Dr. Beth Harley, who's a medical doctor with an MPhil in family medicine, who's been working with City of Cape Town Health in different roles since 1993. And Beth has been involved in HIV work since the 1990s through the changing HIV landscape, including the initial rollout of ART services in 2004, and later moving from clinical care to program support in 2008. She was part of the initial rollout of ART adherence clubs in collaboration with MSF, IHI, and the Western Cape Department of Health in 2010, and has continued this role since. And additionally, since the COVID lockdown in April 2020, Beth is also part of the City Health team that looks at alternative ways for patients to collect medication parcels. And lastly, Dr. Nathan Ford is a scientific officer with the Department of HIV, AIDS, Viral Hepatitis and STIs at the World Health Organization in Geneva, and chair of WHO's Guidelines Review Committee. He holds a degree in microbiology and virology, a master's in public health and epidemiology, a PhD in clinical epi, and a Doctor of Science, and is a fellow of the Royal College of Physicians of Edinburgh. So a very warm welcome to our discussants. It's fantastic to have you join us today, and I'm very grateful for you starting the conversation already in the chat, and all our attendees as well for their various comments. And I think now is a good time to discuss that in more detail. So I'll hand over to you, Andrew, and I'll keep an eye on the chat for any further discussion points that may come up there.
Thanks very much, Nisha, and to all the presenters. It's been fascinating so far. And as Nisha said, I'm standing in for Juanita, who would have done a much better job than myself today, but I'll do my best. And Nisha's going to keep track of the chat in the background and any other suggestions. So I'm going to hand over immediately to the discussants, maybe to Carol and Beth first. You can decide who wants to go first. I know you're sitting co-located somewhere. I think that's the case. And you know, as long as I've been involved in HIV, I think going back 20 years, I remember Carol and Beth being clinically active and involved in program stewardship. So I think your perspectives over this long journey would be really, really interesting, and also any of your thoughts having heard the speakers. So firstly over to you, and then to Nathan.
Thanks, Andrew. It's Beth. I'm going to start. And in fact, Anna, who lives down the road, came and joined us as well. So we've got 3 of us here. And I'm going to start with some discussion around some of the issues that Anna brought up. I loved a slide that looked at group versus individual DSD options. But my experience is that a lot of the efficiencies that we gain through the club system that we use is because they are in groups. And what we've done since we've introduced sort of DMOC Med, which is, you know, the ability to just do a quick pickup of your medication parcel, we have overlaid that for standard club visits. So in other words, the patient experiences as if they're an individual and they just come and fetch their parcel. But the systems behind remain that of a group. And, you know, that changes a lot of the planning and systems and the way we capture the data. There are lots of efficiencies, the batch printing that was mentioned around being able to print the prescriptions, etc. We also have the experience at Ekwezi where there was a fire and they had over 5,000 patients on ART, that about half of those patients were in clubs. Of the half that were in facility, we lost 50% from care during the time that the facility was closed. I mean, I don't think they were lost completely, they went elsewhere, but we only lost 8% of our club patients, showing that this batching and keeping as a group has an incredibly powerful systems usefulness. And we saw the same when clinics had to close for COVID, and we've seen the same with some clinic closures due to violence. We can still run the clubs with very little interruption. We just park the trailer somewhere else for them to do their collections, but the systems can continue. So that was my first point. And I don't know, Andrew, if I should be bringing up all my points or...
Well, why don't we do a round first, Beth, because I think we have less time than I think we had anticipated. And then if there's something else later that you feel would be a good next priority, then you can come back to it.
Okay, thank you. I'm muting you.
Hi, this is Carol here. So I'm going to just respond briefly to Jürgen's question in the chat, although it's not 100% relevant to the issue of DMARC, but it is related. And his query really was around why initial enrollments had stalled and why there was this recycling happening. And one of you did post in the chat a link to the new cascade that Andrew and his colleagues have developed that actually tries to enumerate the extent of recycling at different points along the patient journey. But, you know, just to start off saying that, again, coming from data center, currently 60% of our known HIV positive patients are on ART, 28% were previously on ART. Only 6% have never been on ART. So that 28% really does indicate a serious falling out of care, although, yeah, hopefully recycling to a large extent. And I guess we're trying to look at various DMARCs to try and address that issue. But what I'm going to be saying from here on really is quite anecdotal. I had the privilege of attending a national held training session / workshop on DMARC for HIV earlier this week. And having been out of kind of the substructures for a while, I was kind of quite taken aback by some of the reports happening there. But you know, I think one of the major issues that concerns me at this point in time, trying to explain why patients are falling out of care and often very early, is I'm concerned about the initial counseling that is happening. I think there's a lot of counseling fatigue. I do worry about the same-day initiation. There's a lot of anecdotal evidence that sessions 2 and 3 don't happen, and that a large proportion of patients actually drop out of care by 3 months. And by 1 year, we've only retaining 58% of those patients. Another thing that I think might be contributing to this, and again, it's a concern of mine. There's been a lot of talk on the session about the integration of care, of ART and NCD, and I do worry about effects such as the loss of continuity of care. That certainly in the early times of HIV was a really important ingredient in building trust and retaining patients in care. That is now being dispersed. And likewise, I mean, this concept of integration is not entirely understood sometimes, but some of our clubs have been integrated in inverted commas. And what that sometimes means is putting together in one club patients who are only on ART and patients who are only on NCD treatment. And those are obviously very disparate groups. And given that one of the benefits we hope of clubs is that there is elements of peer support, other opportunities for psychosocial updates on treatment literacy, and that's not going to happen within an integrated club. There is a big concern also that clubs have really largely become pickup points for medication. A lot of these other aspects are falling away. We also, I think, have very poor recall systems at the moment, and it's exciting that the data center is able to produce action lists that Andrea referred to, and also the telemedicine pilots that are taking place at the moment, kind of learning from the COVID experience. The initial pilots at the moment are around TB and sort of early linkage to care, following up on that, and then also patients who've disengaged from TB treatment that can hopefully be brought back. But these models could also be used for HIV, I think. If we come around again, I'd like to talk about the issue of whether clubs should restart, but I'll leave that for now. Thanks.
Thanks, Carol. Nathan?
Yes, hello everyone. So I want to just think about, raise 2 points really. One is summarizing challenges, and the second is about the types of evidence that certainly we at WHO are looking for to try and move the policy agenda forward. So on challenges, echoing what was just said by the last speaker, one of the areas that we're focusing on at WHO is on the preparation that is required at the immediate period after ART initiation. As was said, there is a trend towards starting much more quickly, including on the same day that people are diagnosed. But the question remains, what type of support should they need in that initial period, the first few months post-initiation, in order to set people on a good, solid path and maximize the chances of long-term adherence to treatment. Other challenges we're looking at within DSD are how far can we go? We're at 6 months dispensing of ART and clinic visits. That's what WHO recommends. Could we go to 12 months? And so we're looking to you all and others to see the data that could help inform any future guidance we might put out. Another is how far into the community can we go? So dispensing of ART at community sites and various different approaches have been taken, but it's often quite hard to summarize the very heterogeneous information, but it's something we're keeping a close eye on. And then lastly, as several have discussed, integration, particularly family planning and NCDs. We made a recommendation for integration in the last set of guidelines we put out just over a year ago, but it was a conditional recommendation. It wasn't a strong recommendation because there's very, very limited evidence to support the deliberations that were made by the guideline development group. So more information is very, very welcome. And this leads me to my second point, which is the types of evidence we need in order to inform future policy. Anna Grimsrud started this whole day with a reminder of the history of DSD, and she started at 2015. I would suggest we could go even further back, and at least from my way of looking at things, DSD started in Mozambique in 2008 when MSF with the Regional Ministry of Health had a demand from patients to make care simpler because of distances traveled and the associated difficulties in remaining on treatment. And so the community, the CAGs were formed, and this was a model where individual patients took turns in collecting the medicines for their group, and this allowed patients to not have to go to the clinic every month, but instead every 6 months. That was a very, very small pilot project. It was published in the peer-reviewed literature with just 1,300 patients and 6 months of follow-up. But the idea was so novel that it was echoed very, very quickly to care providers in many other settings, and it was picked up by UNAIDS in their policy documents and informed future research and ultimately WHO guidance. So the point there is to say we don't need large randomized trials to inform policy and practice if it's moving us in the direction we want to go to. The stronger the evidence, the better. But some evidence that can allow us to know that an intervention is safe and works is already enough to get us moving on the global level to change policy. And the second thing I'd like to say, and this is the last point I wanted to make, is that evidence on safety and efficacy of models of care and interventions is really, when I say effectiveness, I mean obviously retention in care and viral load being key indicators, and health status. These are really important pieces of evidence that we need, but that's not the only thing we need. We also look for information that can inform the values and preferences of care providers and clients, feasibility of delivering the intervention in different settings, the resource requirements, how much does it cost, and the impact on things like equity and human rights. So, this is the totality of information that we're looking for when we're trying to move our guidance forward. And I gave a brief summary of some of the questions that are in our minds here. I'll stop there, but I'm looking forward to more discussion and any questions you may have. Thank you.
I've lost my Zoom screen. Can you hear me?
Yes.
Yes, I can hear you.
Maybe I'll find it again. So Nathan, thanks very much for shifting us to evidence. This meeting is billed as a use of an epidemiological lens on routine data, and it's been a very operational discussion. I know there's quite a few people who are attending that have run pilot projects or studies and even published papers that have looked at effectiveness. And I wondered if any of them want to comment. Amy from Hero, or Ketu or Aurelie from MSF, and anyone else who's kind of worked in these areas. So I can't see the hands right now. If you don't mind stepping in, Nisha, if someone does put the hand up.
Yes, Katie Metse has put her hand up.
Go ahead, Katie.
Thank you so much, Andrew, for the opportunity. So I'm just going to speak to the MSF background based on some of the work that has been done in the field to ensure that there's more differentiated services to cater for different group of patients. And one that stands out, and I would also ask Aurelie to jump in, it's the postnatal club. So the postnatal club essentially it recruited both the low risk mothers and the high risk mothers. So this is a club that had like a concussion of both low risk and high risk mothers, mother-infant pair in that group. And it was like some sort of a one-stop shop that I think it's something that can be taken forward, and lessons learned from that aspect of one-stop shop for these mothers, including because these mothers, some of them had high risk in terms of high viral load and all that. And currently in our DSDs, there's some segregations in terms of like disease profiles and stuff like that. And this model has shown to have worked within mothers that have various profiles within them. And the other thing is that like also in terms of the ART refills, like in the first 5 months it was monthly, then afterwards it was 3 months up until 12 months. So this the ART visits, the ART refills were also in line with the baby's immunizations and all that. So it was I think it's something that can be done, and it has been done before in this postnatal club. It's one of the good examples that come to mind when it comes to addressing the complexities that are there in the field in terms of the needs of the patients, that our healthcare system should bend towards addressing the needs of the patients instead of the patients bending the other way around to fit themselves into the healthcare systems. And the other thing that I also wanted to raise is that most of the patients that are lost to follow up, especially in the Western Cape, the research has shown that it's due to migrations of like working in farms and fishing and all those things. And it's something that I think it needs to be thought of in the midst of us taking into account of their bloods, clinical visits and all that, in as much as we're trying to elongate the refill period. Thank you so much.
Thanks very much, Gertrude. I wonder, does anyone else want to come in from the kind of evidence side, responding to some of the challenges that Nathan put to us in terms of what guideline developers are looking for? Amy from the ambit side.
Hi, sorry, I was just fiddling with the unmute. Thank you, Andrew.
No,
Yes,
and
so
please, if you don't mind,
can you
just
hear me?
introducing yourself very briefly as well, just so people have context to what you're doing. Yeah.
Hi, my name's Amy Huber. I'm a senior researcher at HERO and a co-PI of the AMBIT project, and it's a Gates Foundation funded project that looks at a variety of research questions around DSD models and implementation. And so the first thing to state is that, you know, a lot of what we look at is non-inferiority. And so generally DSD models for stable clients have been shown to have equivalent retention and suppression outcomes. But based on the conversation today, I'd like to say that the things we will be focusing on in the near future is the integration piece. And so we have quite a few research questions looking at how can DSD be better integrated into these other chronic conditions. And it's really helpful to hear some of the work that had been done and proposed by your colleagues on the call. And then the second thing we've been looking at is kind of chipping away at the eligibility criteria. And so we did a project in Zambia. We looked at early enrollment into models within the first 6 months of care. And we did find that outcomes were comparable. And then the second one that we looked at is clients on second line. And so in South Africa, obviously the guidelines do cover second line clients, but we found that they also had comparable outcomes to first line clients. And so those are just a few things I can contribute from the AMBIT side. Thank you.
Thanks very much. Can I ask, does anybody know of of something that has been shown to be a risk, a model of care from a DMOC perspective, where the evidence has caused us to pause? Nathan, you would know about it I would imagine, if there were examples.
I'm busy thinking.
Or is there publication bias that we don't hear about those?
Well, I think I'll answer it differently. So I don't have a model that jumps to my mind, but there is a publication bias. Well, I don't know if it's a publication bias or not, but perhaps it is, because and Carol raised this in her intervention, which is the short-term outcomes may look good, but if people have not been adequately prepared to transition into a different type of service delivery approach. I mean, her point and mine was about the being too hurried in initiation without adequately preparing patients. But the same could be said in transitioning from one model to another, if it's not the preference of the client, but rather a policy that's come down from on high, and clients are not necessarily ready to shift to a different model. And there's an choice is a buzzword, but it's a question to me how to what extent programs can truly offer choice, where at a public health, particularly at a public health scale. So the concern then becomes that short-term outcomes look good, but longer-term outcomes may be where the true evaluation is needed to be, because it can fundamentally be about one of the key outcomes of these models is to improve retention in care, to make care delivery simpler for clients, with the hope that there will be better long-term outcomes. And so it's not a traditional publication bias, but it's simply to say we need to not rush too quickly with the enthusiasm of short-term outcomes alone. We need to ensure that there's adequate follow-up to see what those outcomes, what the durability of those benefits are. So Andrew, sorry for not directly answering your question, but I don't have a direct answer, so I thought I'd say something else instead.
Thanks, Nathan. Maybe another lens on that is that on-program outcomes may not reflect population outcomes. So sometimes the availability of a model that allows more people to be initiated may enable more people to be treated in the population, even if the on-program outcomes are slightly inferior. Although what we know is identified a model that's been attempted that has shown inferior outcomes. Can I cycle back to Beth, because I know you had another point and you did raise your hand as well, and I see Jonathan, you also had your hand up. So let's try and take those as the last two comments.
Okay, thanks. I have typed some of it in the chat, but what I really do want to put out there is the support for annual scripting, but it's got to be with the understanding that there are 13 28-day dispensing cycles in a year. And I've done some quite neat modeling around that, which would in fact benefit even 6-month cycles and give everyone a month off between the 16th of December and the 13th of January, because that would be like a bonus month that would be built into scripting, whether it's annual or twice yearly scripting. And I would really like to know who would be interested in taking that further, if there is anyone on this call, because I don't just want annual scripting, I want annual scripting that's been thought through, understanding the maths behind it.
Thanks, Beth. And we haven't had time to cycle back to all of the concerns and opportunities that people have expressed operationally, but I think that that came through very strongly as a pain point, and knowing that there's people have thought through how to address it is very useful. Jonathan.
Thanks a million. Hi, I'm Jonathan Odia. I think for context, I'm a hospitalist in the Mitchell's Plain substructure, and I very rarely venture outside of the confines of our hospital. And it's really encouraging to see all the information, the data that's come from this meeting. I think you get a very skewed view in a hospital setting where you see your very long-term people that have been lost to care for very prolonged periods of time. And interestingly, the vast majority of our patients that are coming through have been lost for an excess of 3 or 4 years. And the things that they have in common is either they've left the province for prolonged periods of time, they've been employed and they have not accessed care as a result of continuously being employed until their health has deteriorated to the point that they're coming with an HIV or AIDS defining condition. And the third group that we see is those that have suffered really bad HIV-associated neurocognitive conditions with really low CD4s. And those are probably 3 very high-risk groups that we do need to probably think of and consider, and they would probably be people that wouldn't be decanted. But my key concern is really that employed group that are lost to care, if the mechanisms cater for them to re-getting into care and being subsequently decanted. And frequently the challenges around frequent collection and not being able to access that enters a vicious cycle for them and never being able to decant and keep their jobs. And that's just an observation purely anecdotally from the very end of the line.
Thanks, Jonathan. And I think the kind of lens that the acute care environment gives us on what's happening in a population is always invaluable, and thanks for those reflections. Just to then wrap up, from the presentations as well as the discussions, I think for me there were kind of 3 areas. One was just talking about models, and from the early presentations from Anna and Romy, I was quite struck by how different the provinces are. There's some provinces where non-facility pickup has been dominant, thinking KwaZulu and Gauteng. Other places like the Western Cape where clubs have been more dominant, although I think we know a little bit operationally as to why that is. And kind of understanding what has made some models work in some places. A few people commenting on whether there needs to be a kind of a good energy put into clubs in the Western Cape context. discussion around group versus individual models and integrated versus non-integrated care, benefits of integration versus loss of continuity. And quite a lot about pain points and opportunities, concerns about the pain of repeat prescribing and also the opportunities of giving that December break. The concerns about the post-initiation care and input that patients get, be it counseling or other post-initiation input. Some digital health opportunities around telemedicine, recall lists, and then the kind of hospital experience around some of the clinical pathways that we've just heard about. And then some discussion around the types of data that are required, longer dispensing, safety, feasibility of new models, resource requirements of models. Some people focusing now on integration, that feasibility and safety is often enough because rather than trying to prove superiority. Yeah, and maybe this meeting has focused less on the epi and more on the operations, but I think for many of us, it's been a fascinating view on something that that is such a dominant and important part of the National Art Program, which again is such an important part of dealing with our largest burden of disease. So with that, thanks very much to everyone. As Nisha has said, this will be posted. And back to you, Nisha, for the to close out.
Great. Thanks very much. What a fantastic discussion. I've certainly learned a lot, and I think we definitely need to keep this conversation going. So I'd just like to say a very big thank you to our speakers, Anna, Andrea, Romy, and Vanessa, as well as our discussants, Andrew, Carol, Beth, and Nathan, for their excellent presentations and discussion points. We really value your insights and recommendations. And thank you to everyone for attending and participating in the discussion. It's been a very active discussion, and we really appreciate all the contributions. The recording will be available on the MeSH YouTube channel, and have a lovely weekend, everyone. I see there's some virtual applause for all our discussants and speakers, so thank you for that. Bye, everyone.